Welcome. It's another week of Anderson Medicine, and this is a really great show where we look at behind the scenes around medicine and around what physicians do as well as others in healthcare. And we've got a really, really good one this week. We've got Navy commander, reservist, ER physician, extraordinaire, diver, like a bazillion other things, Commander Dr. Alan Flanagan. Alan, welcome. Thanks for being here.
Thank you. Thank you for having me.
So, we've talked before about on this show about the Health Professions Scholarship Program. That helped me be in the Air Force. That also helped you. You were a recipient of that. Why did you take the scholarship?
My original intent was actually to be a diving medical officer for the Navy. My father had been in the Navy, so I grew up with an affinity for the Navy. I had a master's degree in nautical archaeology. I used to excavate shipwrecks and got into emergency medicine and dive medicine from there. And my plan was to go on and be a diving medical officer. So I applied for the scholarship, and fortunately I was selected.
We have a Medical Explorers program for the Forest Hills District, and we just came from that. We just came from Alan entertaining for about 40 minutes. You wouldn't actually shut up, actually. You were great. It was awesome. The Explorers, because they kept asking questions and asking stuff. And I just want to, we a lot of times start with a story, and I just want to read this very simple announcement from December of 2012 in the medical staff update. ER physician Dr. Alan Flanagan will be deploying to Afghanistan with the U.S. Navy in January. Dr. Sunny Wong will be serving as EMS liaison because you do liaison with emergency medicine services in Alan's absence. In March, the Service Star. The home is authorized to fly the Service Star of any of our members who are overseas. And so for 1 year, your Service Star, in honor of you, flew in this emergency department until your return. And we very happily, with you there, took it down. So for a year, a Navy commander, Alan Flanagan, was the chief of trauma for the Role 3 NATO hospital in Kandahar, Afghanistan, called the Multinational Medical Unit. And that was quite an experience.
It was.
Walk us through, when you first find out that you're going to get deployed to, you don't exactly just get on a plane and go directly there.
Nope.
What do you do?
Well, the first notification actually came in October. I got a call on a Thursday. It was around 10:10 in the morning. And I answered the phone, and they said, Lieutenant Commander Flanagan, that was my rank at the time, and I said yes. And they said, you've been tagged for mobilization. And they spit it out at you really quickly so that you don't have time to hang up the phone, because apparently that's what some people do. I said, good, where am I going? And they said, we don't know. We just know you're going. I said, when? They said, we don't know. But I said, okay, who do I find out from? And they guided me to my specialty coordinator. So there's a ER doc in the Navy who's sort of responsible for all of the emergency medicine physicians. And I called him up and I asked him, do you know where I'm going, when I'm going? And he was very apologetic, said, oh, the spot had been filled, you're going to Kandahar, Afghanistan. And I was like, okay, good. And I didn't understand why he was all apologetic. I was in the reserves because I wanted to deploy. And so I had, roughly 2 months to get ready. And then we started our training. The training consisted of 6 weeks of training beginning in California at San Diego. There was 1 week there where basically it's just administrative nightmare. You get issued 6 sets of uniforms. And then after that, we went up to Camp Pendleton to do our trauma medicine orientation or review. It's when you start meeting all of your colleagues that you're going to be working with. And for us, it was a deployment of approximately 200 sailors. And you start practicing in teams the way you're going to be taking care of patients. And then after the training's done in Camp Pendleton, we flew on to Fort Jackson in South Carolina. And that's where the Army took control of our training, and they taught us the basics, the necessities of combat and being deployed, traveling in armored vehicles, responses, awareness of IEDs, and just getting us sort of more geared up for where we were going.
So you have to learn to shoot some weapons and be around that?
So as an officer in the Navy, you carry the M9, which is the sidearm. It's a Beretta pistol, and we had to be proficient in that. And then you also had to shoot the M4 or the M16. We were shooting the M4. But fortunately for myself, we didn't have to deploy with it. That was left to the enlisted because they were the ones who would actually be carrying out the security roles. My sidearm was primarily for personal protection, not protection of others.
So you had it with you at all times when you were?
Yeah. We carried our weapon all the time when we were on the base. The only time that we'd take it off is during clinical periods. And then sometimes it wasn't absolute. It was absolute that you removed it, though, when you were taking care of detainees for security issues. But you'd just lock it up in a secure place. We had a armory in the command, and you'd turn your weapon in when you came to work and pick it up before you left.
So the Air Force is pretty much the same, except they don't really let the medical officers even have a firearm, but you have to train. So they tell the story about the detainee that took a weapon off of a doctor, an Army doctor, and that probably story stems from like the 1970s or something.
Probably so, but it's something everybody was cognizant or concerned about. So the primary duty of you beyond your medical care was weapons custodia, or just awareness of your weapon, making sure that you didn't have any accidents with it, it didn't go missing, because a missing weapon or one that's not managed safely can be a threat.
Sorry to ask you about the gun stuff, but I mean, every time military doctors talk, you always wonder about the weapons because they never actually let us, which is a good thing, very good thing. So you got to Kandahar. What kind of hospital did you work in? What was it like?
So the hospital that we worked in, it's the NATO Role 3 MMU, which stands for Multinational Medical Unit. And it was named that because it was part of NATO, which is a multinational group. It was built designed by Germans, built by Turks, and it had been staffed first by Canadians and then taken over by Americans. It was on a U.S. Army base that was an air base, but the hospital was the responsibility of the U.S. Navy. And it was brick and mortar. It was a beautiful facility. It was 2 years old when I got there. It was as up-to-date as facilities can be. We had a 12-bed emergency department, trauma department, and we had surgery services that were right across the hall. We had an ICU on the other side of the surgical suites, and then we had our inpatient. Our inpatient wards at baseline were about 30, but we could augment it up to 90 if need be. Unfortunately, we never needed to at that time. We also had a primary care area. We didn't have a dedicated OBGYN area, but by fortune, our senior medical officer was an obstetrician, which was good because there are still pregnancies in the midst of war. So we were a well-rounded hospital. We also had 2 CT scanners, and we had an MRI unit. The MRI was there primarily for research of traumatic brain injuries. There were 3 in theater, but we were using it all the way until about halfway through my deployment. That's when they disassembled them.
Really?
So yeah, they were no longer doing the research, so they broke them down.
You took the MRI away?
They took it away.
So you had radiology reading the studies?
We had 2 radiologists that were deployed with us, and they read with us. They were there not 24/7, but if I needed to call them in, I could call them in. They were their normal business hours, and then during any trauma. If we had an alpha trauma, which are the worst, everybody, or at least the on-call people, were all there for the alpha.
So when you're talking to the explorers, you walk through like a mass casualty situation where you got called in. Walk us through that, from the first call to what you guys do.
So we had a communication center in the emergency department itself. That way we were in close communication with what was going on in all parts of the AOR, in Kandahar itself, or in Afghanistan. And whenever there was an aircraft or, for whatever, ground unit going out to receive a casualty, we had notification by radio. They were classified as either an Alpha, a Bravo, or a Charlie. Alphas were critically injured who needed to be within our facility or a facility like ours within an hour. Bravos not quite as quickly, and Charlies within a longer period of time. But most casualties were actually Alphas. They would come in generally by helicopter. Our notification could be an hour or two to a minute, or they're touching down. The helicopter landing area was just about 300 yards from the back of the hospital, out on the flight line. It was dedicated for medical CASEVAC and medevac, and our corpsmen would take an ambulance out there and receive the patients and then bring them in. Generally, they would bring the medic that was flying the wounded in to give us a report. So continuity of care was important for us. We'd have the medic come, tell us everything that they'd done for him, every intervention, and give us, as much detail as they knew on the injuries, the interventions, and any sort of past medical history that they might know. When we received them, we would receive them in our trauma bay, which was the bomb-protected area. There was a bomb covering it just out the back of the doors to the emergency department. They would walk them in on a gurney and then taken to one of our trauma areas. Waiting to receive them would be a trauma team that primarily consisted of an ER doc, 2 nurses, and 2 corpsmen, augmented by an anesthesiologist, a dedicated surgeon, and then a surgical tech. We also would have 2 other nurses that would be there to manage the infuser if they needed rapid infusion. And we had a red line about 10 feet from the foot of the cot, behind which everybody else from the hospital stood. That included the orthopedic surgeons, the radiologists, the radiology techs, the phlebotomists, nurses, vascular surgeons, neurosurgeon. We had cardiothoracic surgeons there, but they would all wait behind this red line until they were invited across to do their part in terms of the care. That way we managed patient movement and would get optimal access to the patients for the people who needed to be there.
Did the hospital ever take fire? I mean, did you ever have any issues of
potential
attack?
On an almost daily, maybe every other day, the base took rocket. We had inbound rockets, and there were warnings. It was different types of sirens would go off depending upon if it was a missile attack. It would go off just this wailing siren, and a British female voice would come over the PA system and say, rocket attack, rocket attack. And quite often the warning went off after the impact and the explosion. Sometimes it went off beforehand. There were other warnings that we had, ground attack, which I heard maybe 3 times during my deployment, one of which I was in close proximity to the hospital, and when I ran to the back gate, there was a Slovakian officer standing at the gate covered in blood, and they had been attacked by a Afghan soldier on the base about 300 yards from the hospital. It was a van full of Slovakian soldiers who were our perimeter guards, and they had just finished their shift and were going to lunch when he opened fire on them with a high caliber machine gun. And there was 1 fatality and a number of other pretty devastating injuries from that attack. But other than that, we felt as safe as you can feel in a war zone. Let's put it that way. Not that safe, but yeah. We were probably in the safest spot in the entire AOR.
Would you have to go to downstairs or something when you'd hear the rocket stuff, or stay in the hospital? Or
stay in the hospital, because the hospital was a bomb shelter itself. It was in theory bomb-proof. If you were out and about on base, you would find shelter. Actually, the immediate instruction is to hit the deck, because most impacts will have a point of impact and then they'll spray shrapnel And if you're laying on the ground, it's less likely that you're going to be injured by that shrapnel. If it hits you directly, well, it doesn't matter if you were standing up or laying down. But if it hits in proximity to you, if you're laying down, there's a good chance that you'll survive. So once you go to the ground, when the siren would go down, or after you heard the impact, you were then able to go into a bomb shelter itself, which were all over the base, and stay there until the all clear was sounded. The majority of injuries that we had during rocket attacks were actually from injuries sustained while running to shelter. In one case, a person running into the bunker and hit the top of their head. Pretty bad injury. Another time, a British pilot who was papoosed in his sleeping bag and trying to get to the ground, fell out of his bed and struck his head against the bedside table and had a pretty good laceration. Fortunately, we had a plastic surgeon on staff who was able to repair his facial injury. And those were the majority of sprains, strains, that sort of thing, as people twisted, ran, fell. But as far as I can remember, and I don't remember there would be anybody directly injured by any of the rockets that were fired.
Really?
The rockets were Chinese-made rockets that the Taliban got a hold of. And they were basically, they had a very short range. They were fired from within a mile or two from the perimeter of the base, and without really much directional guidance at all. They were put on a berm of dirt or a makeshift rocket launcher and just sort of lobbed onto the base itself. Many of them missed, a few impacted. The closest to the hospital itself was probably about 250 yards at one time. It impacted just on the other side of the fire department. And the fire department itself, and this was the airport fire department, so it faced the tarmac. It got a little shrapnel damage, and it definitely startled us, those of us who were close by. I was probably 100 yards away from the impact when it occurred. I was walking to work. It was early in the morning, and it hit the ground. Hit the ground fast. And that one went off before the alarm went off. So
yeah,
it was hit the ground, or impact hit the ground, alarm sounds.
Yeah. So if you're just joining us, you're watching Anderson Medicine, and you're watching Commander Alan Flanagan, who's an ER physician here at Anderson Mercy Hospital. And you got a suit on. What's up with that? I've never seen you with a suit. You're all dressed up. In fact, you don't even wear a white doctor coat, except for, we were just talking about, the only time we wear our white doctor coats is when we have to give bad news.
It is.
Because it's kind of an infection risk. You were talking about that.
Yes. Yeah, the research has shown that it's a harbinger of infection, because we don't clean them like we should, and we're wearing them from room to room to room. And so it's probably better not to wear the white coat than it is to wear the white coat. And the worst culprit is the tie, which I never wear. So it was one of the reasons I enjoyed being in the Navy, is very few of our uniforms have ties.
Yeah.
At least none of the uniforms I work in had them. So.
Well, I'm honored that you chose to dress up for the big TV interview here. So how big was the base? And so it was mostly an air station, or you guys were right next to the flight line? Or?
Yeah, so it's an air base. At the time that I was there, and for I don't know how many years before, it was the most active single strip airfield in the world. The amount of flights going in and out of it, both commercial and the military, including jets and drones and transport units, the amount of volume was spectacular. It was actually quite entertaining to go and sit on the flight line and watch everything fly in and fly out, especially the drones. That was a unique experience. But we also had heavy lift craft that were coming in regularly with equipment that they were bringing to the war and then ultimately taking away from the war, because we started to wind down while I was there. The base itself was about 29,000 when I arrived, dropped down to as low as 25,000 during my time there, but then picked up again because it became one of the rallying points for removal of troops. So we would get a lot of the troops that were going home coming to Kandahar. But of the, say, 29,000 that were on base, less than 10,000 of them were active duty. The rest of them were civilian contractors. And both Americans and multinational and third nationals. We had TNCs, third national contractors, which are from other countries that aren't part of NATO, but they're friendly countries and they come to support us. A lot of individuals from Africa and from Asia and to there and take care of the war effort.
And so you took care of a lot of casualties, and I wrote this down. A casualty that made it to your hospital had a 99.8% chance of leaving alive.
During the time that we were there, it was close to that. During the entire, I think, during the entire time that this new facility has been there, it was about 98%. That didn't mean that they survived their injuries necessarily, but for those that were devastating injuries who we pretty much knew were going to pass from their injury, we could get them either to Germany alive or get them stateside alive such that their family could be with them in their last hours or days.
People don't realize when at these military hospitals, there's like every specialty in droves, ready, waiting. The level of care is, how does it compare to a typical trauma center? So this is a Role 3 hospital, which would be kind of like a Level 1 trauma here in the States, or
similar. Yeah,
how does it compare to the typical car accident in Cincinnati?
So in many ways, we'd have the same depth of specialty, but we wouldn't have quite as many. Like we'd have, one trauma surgeon per se, and then a cardiothoracic surgeon or a plastic surgeon who would be acting in the role of a general surgeon or doing trauma surgery. And we had a staff that, for the emergency department, for instance, we only had 5 doctors, and we staffed this ED with 5 doctors 24/7. So fortunately, our patient volume wasn't comparable to a Level 1 trauma center in the U.S., but we did have the expertise. There were some areas where we were a little short. We only had 1 pediatrician on our staff, and he was an ICU pediatrician. And you'd think, oh, well, in a war zone, you don't need pediatricians. But in fact, there are a lot of kids that become casualties. And any child who is injured, especially children that were involved in some operation that the NATO was involved in, they became a patient of ours, and we cared for them. I guess the only other thing that during the time that I was there, we didn't have a dermatologist. We did have an ophthalmologist. We did have an incredible oral maxillofacial surgeon, remarkable and plastic surgeon. So it was a lot of expertise there. It's
amazing what you can do in times like that. So a couple of things, you talk about. Where did you live? Did you live in the hospital? Did you go to a house? I mean, where did you go?
We lived in barracks, NATO barracks that were about a 10-minute walk from the hospital itself, 5-minute run, depending upon whether or not you had your helmet and your armor on. And they too were built at the same time the hospital was, and built very much in the same way. So they were bomb-proof or bomb-resistant. And that's where most of the international NATO groups were there. Though our Army, they had their own areas, and the Marine Corps might have their own areas, but we lived alongside with Canadians and French military and Germans, and it was quite a mix, a melting pot, if you will.
Yeah. What did you do for fun?
We worked out a lot. So when things weren't busy, spent a lot of time in the NATO gym, which was conveniently right beside the NATO barracks. The hospital itself we had our own little gym. I would say on average, people were doing at least 2 days, maybe 3 days, if that was their schedule. For us in the emergency department, we didn't have it that much time off. We were a little busier because we did a lot of just the primary care medicine as well for the base. There was a very nice boardwalk on the base that had been built over the years that actually had a 3/4 size soccer field, artificial turf soccer field. There was a cement hockey rink that the Canadians had built. So there was a lot to do. There was enough to do.
You're talking about kids, and you mentioned the story earlier today about this Afghanistan kid that was injured. Tell that story. That was really kind of shows what military medicine is to me.
So it was our first patient, my first patient, just after we got there. And he was a Taliban who, by report, had been planning an IED, roadside IED, improvised explosive device. And a drone dropped a missile near him. Didn't hit directly, but near enough that he was severely injured. His entire backside was peppered with shrapnel. The British commandos then swooped down and rendered aid. They put him on a helicopter and flew him to us. Now, every time that we got a detainee who came in, they were blindfolded and they had hearing protection put on them so that they couldn't see or hear where they were going or what was happening. And it wasn't removed until they got right onto the gurney in the emergency department. And when he got to the gurney in the emergency department, he had the entire trauma team standing around him. So no less than 4 doctors, 4 nurses, 2 corpsmen standing in surgical gear with face masks and hats and everything, gloves, looking down at him. And I took his iPro off, and he must have just been horrified. Judging by the looks of him, he'd probably never worn shoes, just looking at how calloused his feet were. So the building that he was in, I can guarantee he'd never seen the likes of. And it was bright white and lights shining down at him. He probably had no concept of what was going on. And it was difficult trying to reassure him that we were there to take care of him. Now, we did have interpreters. So we had an interpreter talking to him the whole time, trying to reassure him, trying to explain, trying to ask questions of him, see if he had any medical history, tell us where his pain was, so that we could treat him. The rules of engagement, rules of war are such that, once somebody's injured, doesn't matter what side they're on, we're taking care of them. So we're going to take care of our own, and anybody that we come across that we've injured or has been injured in the course of war, a detainee, they become one of our patients, and we treat them the same.
Excellent. Alan, Commander Flanagan, thank you for your service. Thank you for coming on and talking with us. It has been, once again, a pleasure. We talk like every day. And,
yes, we do.
And usually you're calling me like for an admission or whatever. But thank you. Thank you.
Thank you.
You have really, been there, done that. Would you go back?
In a heartbeat.
Yeah, I thought you'd say that. So in the news this week, you may have noticed there's a large building project going on at the hospital, a $70 million 5-story tower that's coming up out of the ground to be completed in July of 2016. And next week, we have the 2 guys building that tower. Larry Bagby, who's the Director of Construction Planning and Construction, and Neil Fetters, who's the Director of Operations, will be here. As part of that, we need some design things. And so each year, we've gone to Nagel, starting with the parking lot project. Last year, it was the ICU waiting area that a group of students designed. And this year, it was the dining area. And so last week, we had the 31 finalists of 12 teams come and present to the hospital leadership. This morning, we awarded the finalists. We awarded the winner. And so congratulations to the design team of BKFK design team of the 8th grade at Nagel Middle School, Amy Bushman, Gretchen Kirsch, Dana Coury, and Caitlin Fisher, who will be with us in early May to present to their families and our staff leadership their design. And so once again, thank you for watching Anderson Medicine. I'm your host, Dr. Steve Fagans.